Friends, today our topic of discussion is systemic sclerosis. So we will be talking what is systemic sclerosis, what is its underlying pathophysiology, what are different clinical presentations of this disease, and what tests we do, how do we diagnose it, and how do we treat this disease. So as the name implies, systemic sclerosis. Systemic means it can involve multiple organ systems of the body. Multiple organ systems. And sclerosis means fibrosis. Fibrosis. Pathologically speaking, it means replacement by collagen fibers. Replacement by collagen fibers. So initially there is edema that leads to induration and ultimately sclerosis occurs. So sclerosis means the final stage in the pathophysiology of this disease. So if you see the pathogenesis, so both genetics and environmental factor play a role in the pathogenesis of this disease. Genetic means certain HLA genes are susceptible, and environmental means infections, occupational exposure of silica, occupational exposure, and infections include either virus infection, fungal infections. Okay, so these infections trigger this autoimmune inflammation, and you can see there are basically three dysregulation. One is immune dysregulation, diffuse microangiopathy, and fibrosis. So you can see variety of cytokines, chemokines, growth factors. These drive this immune dysregulation, fibrosis, okay, and that leads to diffuse microangiopathy. Regarding epidemiology of this disease, you can see female is more commonly affected than male. The ratio is 3:1 to 8:1. And regarding the presentation of a patient, you can see multiple organ systems are involved. Not only skin, but multiple organ systems are involved. In skin, you can see induration, calcinosis cutis. Calcinosis cutis means it is dystrophic calcification. The calciums are deposited under the skin. Telangiectasia occurs. You can examine with nail fold capillaroscopy, hyperpigmentation, xerosis, and in digital tips you can see Raynaud phenomenon, and there can be digital tip ulcers as well that ultimately can lead to acroosteolysis. Acroosteolysis, resorption of the terminal phalanx leading to shortening of digits. Shortening of digits. In mouth you can see xerostomia, reduced mouth aperture, mucocutaneous telangiectasia. Upper GI tract you can see gastroesophageal reflux disease, gastric intravascular ectasia, Barrett's esophagus, gastroparesis. In lower GI tract, hypomotility, small intestinal bacterial overgrowth, pseudo obstruction. In musculoskeletal system, joint contraction, tendon friction rubs. In lungs, ILD, pulmonary artery hypertension. So talking about ILD, NSIP pattern is more common than UIP pattern in the systemic sclerosis related ILD. And you can see heart is also involved. In heart, pericardium involvement can cause pericarditis, effusion. There can be cardiomyopathy, diastolic dysfunction, arrhythmia. Okay, kidney can be involved. Here you can see kidney can be involved, leading to scleroderma, renal crisis. And this disease is further subdivided into four categories. One is limited, second is diffuse, third is sign scleroderma, and fourth is overlap syndrome. So what is difference between limited and diffuse? Limited and diffuse. Limited means it is limited distal to elbow, and it does not involve trunk. Trunk no involvement, but here trunk is involved, plus it is extends proximal to elbow joint, proximal to elbow knee joint. Okay, face can be involved in both. Face involved can be in both, and the difference is that this is the rapid progression occurs in diffuse cutaneous systemic sclerosis, but it is slow progression, and more organs are involved here. More organs are involved in diffuse than limited cutaneous systemic sclerosis, but it is not that no organs are involved in limited. There can be, but the prevalence is less. And sign scleroderma means there is skin sparing, but internal organs are involved. Internal organs are involved, but skin can be sparing. Overlap syndrome means this disease overlaps with disease like rheumatoid arthritis, SLE, Sjogren syndrome. Okay, and do you guess what is this syndrome called? All this picture combined, this is called crest syndrome. So here you can see calcinosis cutis. This is Raynaud phenomenon. This is calcinosis cutis. This is esophageal dysmotility. This is sclerodactyly, and this is tenalgic tasia. So CREST, crest syndrome. So how do we diagnose? So apart from skin induration, if there is typical visceral organ involvement, then we can say with high degree of certainty that there can be systemic sclerosis. And there is one Euler criteria, and in this criteria, if it comes 9 point or greater, we can definitely call this systemic sclerosis. And you can see highest point, 9 point, is given for skin thickening of the fingers of both hands extending proximal to MCP joints. If there is poppy finger, 2 point. If skin thickening of whole finger distal to MCP joint, 4 point. And if digital tip ulcer, 2 point. Pitting scar, 3 point. Tenalgic tasia, 2 point. Abnormal nail fold capillaries, 2 point. Pulmonary arterial hypertension under ILD, 3 point. And Raynaud phenomenon, 3 point. And if you get 9 point or greater, then we have high degree of certainty that it can be systemic sclerosis. And these are various autoantibodies that you can find in systemic sclerosis. ANA, you can see 90% of the patients ANA positive, and there are variety of speckling pattern of ANA, like a speckled pattern in SCL70, and you can see more frequently in diffuse cutaneous systemic sclerosis. If there is centromere antibody, it is most likely limited cutaneous systemic sclerosis, and RNA pol3 antibody, most likely diffuse cutaneous systemic sclerosis. But it is not found in all 100% of the patient. You can see this is also the percentage of the patients in which these autoantibodies were found, and depending upon the autoantibodies there can be organ involvement. Like if lung fibrosis, isolated pulmonary hypertension, less likely. In this condition SCL70 is more likely, and pulmonary hypertension, esophageal disease, and there is protection from lung fibrosis and renal disease if centromere antibody is positive. Okay, and if RNA pol3 antibody, then you can see there is high chance of the renal skin malignancy. So talking about treatment of systemic sclerosis, these are various immunosuppressants that can be used, and these are antifibrotics that can be used for ILD. These are specific treatments like dihydropyridine calcium channel blockers, nifedipine, that can be used in a Raynaud phenomenon. ARBs, these can be used in for scleroderma renal crisis. Alpha 1 blockers if hypertension, 5-phosphodiesterase sildenafil, that can be used in pulmonary artery hypertension. Similarly, topical nitroglycerin, IV prostaglandin, endothelin antagonist, this also can be used in pulmonary artery hypertension, and these are other adjunctive therapies like aspirin, dipyridamole, statin, antioxidants. And regarding treatment of systemic sclerosis related ILD, if the absolute decline in FVC is 10% or greater, or DLCO fall is 3 or greater over 12 months, or immediately for extensive asymptomatic cases, you can see mycophenolate or cyclophosphamide can be used. Okay, and for maintenance therapy we use mycophenolate. And for pulmonary artery hypertension, we can use endothelin antagonist, phosphodiesterase inhibitor, inhaled prostaglandin analogs like iloprost, and also vaccinate. For renal crisis, we prefer ACE inhibitors like captopril. But if ACE inhibitors are not available, then we can also choose for ARBs. Okay. And in addition, we have to manage associated symptoms like seizure, pulmonary edema, tachyarrhythmia, severe AKI. And regarding course of disease, you can see the natural course is highly variable, and there is increased risk of premature death. And I already told you diffuse disease has rapidly progressive course and worse prognosis than limited forms. And major cause of mortality like pulmonary artery hypertension, pulmonary fibrosis, GI involvement, cardiac involvement. Okay, and what are poor prognostic markers? Male sex, older age at onset, trunk involvement, palpable tendon friction rub, significant and progressive internal organ involvement. And what are poor prognostic lab markers? Elevated ESR, proteinuria, anti-topoisomerase 1 antibody. So in nutshell, we can say this is a autoimmune connective tissue disorder where there is vascular dysfunction and progressive fibrosis of internal organs. There is a protein clinical manifestations, and this disease has been classified on the basis of serological markers, organ involvement and skin involvement, and treatment is individualized on the basis of manifestations. So this is all about systemic sclerosis. If you have any queries, you can comment it down and I'll be happy to reply it back. Thank you.